Hello everyone, my name is Dr. Denise Ejo, the CEO of Cornwood Cancer Foundation. I would like to welcome you to our Cornwood Cancer Foundation page. Our goal is to create an awareness of the challenges, support and guidance experienced in managing cancer care for sufferers, family, carers and friends. To engage with us, don't forget to subscribe to our channel, click our notification bell.
Webinar. Is it a webinar? We call it a Zoom meeting where we talk about cancer and we relate with people who have or are going through the disease. Today we're going to be talking with people, with specialists on mental health. This is the mental health month, and we're trying to look at mental health and cancer. What are the impacts? How does it affect people who are going through cancer? What are the things that people need to do if you know someone who has challenges mentally because of cancer? Cancer has its own challenges it brings with it, and the pains that go with it make a significant difference. So our medical well-being is one aspect that will take us through the journey. However, our emotional and mental well-being is very important, which I think is something I have been able to pick up as a person. So today I want to introduce our three main speakers, and I'm going to start with Benga Oyesomi. Benga, will you quickly do a brief introduction? Or rather, do you want me to do it for you?
You can do it for me. I sent you my bio.
Yeah, I have to ask now. I like the fact that I could do as I like. So I'm going to do Benga first, and let me read this one. So let me tell you about Benga. This in America. Benga graduated with biochemistry with a BSc in 1985 and an MBBS. Don't know what that is, from OAU. Correct. In 1991, Benga did his residency at the Albert Einstein Medical Center and holds a graduate degree in marketing from the Wharton School of Business. That's also in Pennsylvania. He has a master's degree also in public health from Drexel University, Philadelphia. He's a trained physician with a strong background on psychiatry, public health, evidence-based medicine, biostatistics, health technology, assessment, health marketing, and peer-reviewed publications. Benga, welcome on board today. And thank you for joining us.
Thank you very much.
The next person I'm going to be introducing is Dr. Ogbulu. Well, for me to introduce Doc, I will also add my own spin on Doc as well, because we do different things together as well. So Dr. Ogbulu is, Doc, did you send me your own citation? Yes, you did. But I can't read the whole thing, so I'm going to try and do as much as I can. Maybe I should put all the degree part in. After that, I will do my own, right? That's okay. Okay, so Doc is a graduate, is a medical doctor, and he graduated from the University of Illinois, and he said Anambra State. His residency is in psychiatry and was the overall best nationwide in the National Postgraduate College of Medicine in Nigeria, the exams in 2004. He has served as a secretary of the Medical and Dental Consultants Association of Nigeria, Luth chapter, and the then chairman between 2014 and 2016. Now, from my own, I'm going to go back. He's also the national coordinator of SERPIN. SERPIN is the Suicide Research and Prevention Initiatives in Nigeria. I want to now add in from that point, because I can talk about Doc. Dr. Ogbulu also works with children with mental health challenges and works with a view to making sure that the doors are open to ensure people do not provide a platform to allow people know there is support rather than trying to get out of the battles. So, Doc, I'm going to leave it like that because I will be adding in as I go, considering I know you personally, and we have and we do work together on Suicide Watch. I call it Suicide Watch. I don't know why I do that, but sorry, that's what I call it. And I'll go at the top, Prof. And the next person is Professor Chioma, our lady in the house. And Prof doesn't like to talk too much. So I want to see whether Prof was even nice and gave me something to read. Okay, Prof, you didn't give me something to read, though. Prof is an oncology consultant.
Psycho-oncology.
But you see why I just said Prof didn't give me something to read, so that has already given me. And now to even name the things, the problem has come. So I'm going to leave your own, and then at the end we'll come to that. I hope you don't mind.
No.
That's psycho. I will start getting the English wrong. You see, medical people, you have very big grammatical words, and I am very good at recognizing it's not a very good strength of mine. So let's move on. So firstly, I will start with Benga. Can you please come on and give us a briefing on your concepts and how we look at cancer going mental health and cancer going forward? Where are you? You are unmuted.
Okay, thank you. First of all, thanks to our Miss Denise for putting this together, and also members of your Cancer Foundation. It's really a privilege to be part of this. I want to acknowledge the other distinguished speakers, and also the audience. Thanks for finding the time to be part of this presentation. So as Ms. Denise had introduced me, I've been working with cancer patients since 1999 at the Borden Cancer Treatment Center in Philadelphia. It's the treatment center affiliated with Thomas Jefferson Teaching Hospital. So I'm part of the team there. So talking about mental health and well-being, for patients with cancer, first of all, I want to define, because I'm going to look at this from the biopsychosocial aspect of cancer, which is how I was trained here. So first of all, what is health? According to World Health, health is a state of complete physical, mental, and social well-being. So it's not merely the absence or presence of infirmity. So, let me talk about the risk factors. First of all, some people might have what you call pre-existing mental illness or psychological distress. Some people might have comorbid conditions, and some might also, lack social support, such as, transportation to an appointment, preparation of meals, help with basic activities of daily living, emotional supports, and even the opportunity to talk to someone, share your feelings, concerns, and emotions with someone. So if you have, some of those conditions already, everything is going to be amplified. So I'm not going to talk about how you manage the biological aspect, because we're not here to talk about that. But I'm going to focus more on the psychological and social aspect of cancer, because they both go hand in hand. So what are some of the psychological, problems, people might have, dealing with body symptoms, pain, fatigue, fear, sadness, depression, even spiritual problems. When someone has cancer, back in the days, it was almost like a death sentence. You have cancer, it's like, my life is over. Some of the social problems could be, loss of job, problems with your partner, family problems. So let's talk about the psychological aspects. depression, anxiety, stress, anger, suicide, fatigue, pain. They all, affect people with cancer. And then even the fear that the cancer might reoccur, you know, um, worry, trouble sleeping, you're anxious about even going to the doctor. So all this, they're like a recipe for, problems to happen. So how do you treat some of this psychological, presentation? Of course, you can use pharmacotherapy, medications. But, we're not going to go into all those types of classes, but just to know that, medications are there for you. Also counseling and psychotherapy, the different types of psychotherapy, CBT, cognitive behavioral, mindfulness, yoga. I mean, so many things, but we're not going to go into all that, but the objective really is to help, the person, because I try not to use patient, the individual cope with this illness, because you have the cancer, but you have to be able to cope somehow. And then also, if you're on medications, most of the psychiatric medications have a lot of adverse effects. A lot of them have adverse effects. So how do you monitor them? And based on the adverse effects, some of the patients might not even comply. And if there's poor compliance, it's going to make things worse. And you want the individual to be actively involved in the whole treatment. So you don't want to be the mental health person just, spewing out things for the person. You want them to be involved. You want them to take some self-responsibility, and you want to give them some self-esteem, because someone has cancer, their self-esteem, usually, is, attacked. So you want them to feel confident that, okay, you have this cancer. However, together, we can beat it, you can beat it, and I'm going to be there for you. So you want to empower them to make self-decisions. You don't want to make the decisions for them every time, because, they might think, oh, because I have cancer now, you're telling me what to do. So you want them to be part of it. And also support groups. I can't emphasize that enough, support groups. You want to meet other people that have been through what you've been through. You want them to give you hope, encouragement, and also faith-based, especially in our culture, the Nigerian culture, where, the church, the mosque, or whatever faith you practice, it's huge. People still look up to their pastors or their imams, or, whoever they believe in. And trust me, you just want to give them hope. You just want to give that individual hope. So let's talk about, next thing I'm going to talk about is, I'm just going to talk briefly on.
Yeah, why?
I want to talk about two types of cancer briefly. Men, I'll talk briefly on prostate cancer, and women, more breast cancer. So briefly, prostate cancer. In men, some of the problems that will cause, mental health problems, the man, impotence, erectile dysfunction, we're all adults here, sexual issues, urinary incontinence.
Well, put it back to number Jack.
Years ago,
you are on your phone.
I did a job.
I need a joke. Okay.
Oh, he's joking with you.
Okay. Things happen. There was a judge who had prostate cancer.
You don't do that. No.
Was leaking urine.
Don't do that.
And the judge ended up the judge in Philadelphia, who committed suicide because he was leaking urine. So some of those things, has to be done. In prostate cancer, you have what they call prostate-specific antigen testing. So when men want to go for the testing, there's a lot of anxiety. And, based on some focus groups that I did in Philadelphia, a major problem with men is the rectal examination. When you do the rectal examination, doctors here will know what I'm talking about. You want to feel the prostate. And most men here in America, especially the Black men, it makes you less a man. If you go back to the hood and your friends here, oh, you had a rectal examination. And then generally, most men don't like to visit doctors. I'm a medical doctor. I always have, some palpitation if I have to go for a medical examination, and I'm just being honest there. Let's talk about breast cancer briefly. Some of the problems with, breast cancer, it causes disfigurement, loss of hair, understanding the disease, overwhelmed with the medical visit, the procedures, and you need to, there are just so many types of treatment modalities for all this cancer, treatment, because it's part of the mental well-being. So if a man has prostate cancer, there's what they call watchful waiting. Most men will die with the prostate cancer. The prostate cancer will not kill them. But how do you tell someone, don't do anything? I have cancer, I have to do something. So the role of the psychiatrists, the therapists, the counselors is very huge. So I'm not going to waste too much time here. Some of the psychosocial conditions and coping stress, quality of life, treatment decisions, experiences with the illness, subjective conception, some of the Ds, the discomfort, the dependency, disfigurement, disability, disruption, disengagement, and death. And of course, when someone has cancer, they have to deal with grief and, the stages of grief, denial, anger, bargaining, depression, and anxiety. So in summary, because I'm trying to keep this short so we can have questions, psychological distress is a frequent and relevant problem in patients diagnosed with cancer. Psychological stress reduces the quality of life and affects the history of the disease and the satisfaction about any treatment. Psychological distress should always be treated by a professional, with the support of other people. So psychological support is a crucial part of the multidisciplinary management of patients with cancer. So usually here in the US, most cancer institutes, the oncologists, they have psychiatrists and psychologists as part of the team. So as they are treating the biological problems, you have to know these patients have psychosocial needs. So it has to be addressed. So that's all I have to say. Thank you very much.
Thank you, Gbenga. Thank you very much. Thank you. We're not going to take questions yet. You want to come off your screen? Thank you. We're not going to take questions yet because we always have a focused question and answer session where everybody will now be on the hot seat. Next person to speak, Dr. Ogbolu, it's your turn. Dr. Ogbolu is going to be coming in at this conversation from the impact mainly that it can have on the mental well-being. That the statistics already shows that men are the highest risk of killing themselves because of cancer. So good luck to you, doctor, but there are quite a few men on the platform today. I'm very, very happy. It's very nice to see men on the platform. So enjoy yourself.
All right, thank you so much. Again, as Denise has mentioned, I'm a consultant psychiatrist and the national coordinator of the Suicide Research and Prevention Initiative. Now, I worked for close to a decade as the overseeing psychiatrist in psychiatric consultation liaison in Louvre. Now, what that means is the division of psychiatry that tends to interface with other forms of fields of medicine. So if there was a problem, psychological problem, somebody who had obstetric issues, surgical issues, other medical, I would go to see them. So this brought me in contact with a lot of people who had cancer on other wards that were psychiatric wards. And it's opened my eye to a lot of the sufferings that people go through. So I'll be speaking mostly from a point of view of experience rather than theory. Now, let me just start off by saying that of course, mental health can impact on virtually every condition, okay? But there's particular importance when it comes to cancer and dermatology. they seem to be, when people think of other forms of medicine that really has close link with psychiatry, they tend to think of neurology, which makes sense really. But by far, dermatology, skin issues, and cancer are very, very, very closely linked to mental health. And the reasons why are this: one, they both tend to suffer stigma. And stigma can come from the physical or disfigurement that comes with cancer, the physical, the ones that show outwardly. Then also the preconceptions that people have, misconception, myths. So that also, there's a lot of self-stigmatization associated with both mental health and cancer. The other thing is that why cancer is significant is that it causes not just physical pain, but also psychological pain. And people find it very difficult to relate with the concept of psychological pain, but it is real and it can really take a huge toll on the person. The other thing is that they're both associated with some degree, quite significantly, disability. Mental health on its own can lead to disability, then just having cancer can also lead to disability. So it's very important that we have this talk. Now, the things that bother me when I often went to see people who had psychological sequelae of cancers are that, one, it starts from the diagnosis. And that's because people have different expectations. People have misconceptions, beliefs. Of course, there's a tendency, we tend to over-spiritualize things in this part of the world, Nigeria, so they would first seek other forms of treatment. So not accepting the diagnosis was very common. So a lot of them would present pretty late. Now, the process of going through the diagnostic procedures could also be very, very distressing and cause a lot of fatigue. So what we tended to see during those periods when the issues related to diagnosis of cancer were anxiety. Illness anxiety was so prominent. And then a number of people also depression. So that had to do with the diagnosis. Then we moved, of course, don't forget the issue of travel for diagnosis, because sometimes you have to go to places far away from where you live to get proper diagnostic procedures done. So that was usually a first challenge. And then came the issue of treatment. And of course, you could have chemotherapy, radiotherapy, or surgical intervention. And so that also came with its own psychological problems. And in this case, we often saw, again, anxiety, and then we would see depression begin to set in most of the time. Sometimes the surgical procedures could lead to the disfigurement, and then that begins to feed off on the person's self-esteem. And then that tend to compound everything. So treatment itself, then, of course, as was mentioned by Gbenga, that sometimes the medication we use to treat mental health condition, but also some of the drugs used in treating the cancer itself can lead to psychological complications. And so people may have hallucinations, people will have sleep problems, and then we begin to see a lot of insomnia during those periods. And then, of course, insomnia tends to beget depression. And so that's the stage where we also begin to see substance abuse beginning to feature. People begin to go seek alcohol as coping mechanisms and other forms of drugs. So that's with treatment. Now we then leave treatment and then go into the economic impact that it has, because a lot of times the person may not be able to work again. It takes a huge toll on the family as well. And so sometimes the psychological impact that the person has is from the affectation of family members. They also don't know how to deal with it. Sometimes we've seen that it's family members who even go into depression. And so the person who has cancer has to deal with being strong for people who have now become depressed because of their condition. And so then we begin to see guilt. Guilt begins to feed in, and then what did I do wrong? And second guessing choices in life and things like that, especially for things like people who were smoking and things like that. So again, depression becomes quite prominent. And it's usually at the stage of treatment that we've often had to come and see people on other wards who had attempted to end their own lives. Again, it's sometimes related to the stress of going through the treatment. And I mean, sometimes the treatment outcome is not as expected. So people have different expectations. So not managing the expectations well also could be a problem. Some have the expectation that with each treatment, there should be a drastic change. And when that doesn't happen, we tend to see a lot of people become depressed and the hopelessness begins to feature. And once hopelessness has begun to feature, that's when they begin to think of suicide. Now, very importantly also is that people who have cancer, and the elderly, particularly the older ones, that's when we begin to see a lot more passive suicide. So the person, for some reason, you are frustrated as the therapist, either the surgeon, the radiotherapist, because the person is not complying with treatment. And you can't, and it's very frustrating for the doctor, I mean, whoever's involved, because you keep telling this person, this is what you need to do, this is when you need to go, but they don't. And nobody thinks about the fact that the reason why some of them don't is they want it to end soon. So they may not actively go to seek to, end their own lives, but that's their own way of ending this passive suicide. They refuse to comply with treatment with the hope that, look, let me just exit. So, and it often has to do, unfortunately, and I've had a number of run-ins with colleagues, because one of the bigger frustrations I've had is that people do not talk to patients. And I get to the ward and I'm having to tell them, do you know what's the recent investigations, what the recent results, and they don't, nobody has spoken to them. So that itself was oftentimes a frustration on the part of a person going through cancer, because they didn't know, they weren't carried along in the treatment. And that's a very vital aspect of, dealing with it, being actively involved, knowing that what the next things are. So that was often a very big frustration that I often encountered as well. Then, of course, one, as Benga said, it's a multidisciplinary approach that should be used. Unfortunately, we often, for lack of personnel, we often don't do that in Nigeria. So you would most oftentimes not even see mental health involvement. It was usually when I would go see the patients on the ward that I would then write that the clinical psychologist has to be involved. That whoever is managing, whether it's the surgeon or they need to write to the clinical psychologist to come and see the patient. So it's sometimes, because it's not always just the issue of medication, but our colleagues sometimes do not think along that line. They're just thinking about, cut and go home. Come for your radiotherapy and you go home. No, it should be more than that, because, as I said, oftentimes some have argued that the psychological pain sometimes is more than the physical pain. Some said it's the other way around. Some say they are at par. So, but we often, non-mental health oriented physicians often think of the physical pain without the psychological pain. So that's usually a problem. And why I say that is it's not just the psychologists. What pains me a lot is a lot of people needed the occupational therapist involved. And at some point in the whole hospital, we didn't have up to 5. So, and you had a hospital of over 800 beds. So it was difficult. But the fact was, people didn't even think that an occupational therapist needed to be involved, because life changes come along with the diagnosis and treatment of cancer. Some may not be able to run their business again. Some may not be able to go to work again, care of the family. So occupational therapist is crucial in managing cancer on a broader term. So those were the things that I tended to find as issues. So the common mental health issues encountered would be initially the anxiety usually would feature first, as I mentioned, then come along the issues of substance abuse, insomnia, then depression, and then oftentimes suicidal ideation in some cases. Then there's psychosis. And psychosis, I'm rounding up now. Psychosis is mostly because oftentimes you have the cancers that primarily have no involvement with the brain, and then you have those that will have involvement with the brain, either through metastasis or they primarily occur in the brain. And so people may have hallucinations and things like that. And why it's important that someone with knowledge of psychopharmacology is involved is because certain antidepressants, certain antipsychotics are preferable when people are taking other forms of medication than others. So somebody who doesn't have that knowledge may not be in the best place to help the patient. So I'll leave it there, and then hopefully as questions come, we'll answer. Thank you.
Thank you, Doc. Thank you very, very, very much. And then we've got Prof in the house, consultant, oncologist. Let's move on from that, because if I even attempt to use the correct words, I will get it wrong. Prof Chioma, please can you unmute yourself, because I'm not holding you back. Okay.
Okay, thank you very much. Are you hearing me?
We are.
Okay. I am Chioma Asuzu. I am a clinical psychologist, psycho-oncologist. I'm the current head of Department of Counseling Psychology, and I'm jointly appointed in the Department of Radiation Oncology, Unit of Psycho-Oncology, University College Hospital, Ibadan. I'm specialist advisor in the area of psycho-oncology in UCH. So I thank you so much, Denise, for this opportunity provided for us to share. You know, that's what I will call it. And I thank my colleagues who have spoken earlier, and I thank you for your presentations. So the issue of mental health and cancer, I think we are all going to be talking around the same axis, you know. I hope I've written it. I have just a few slides here to talk about concept of cancer, to talk about breast cancer, to talk about some of the psychosocial issues involved in cancer. Mental health, what is it? What is mental health state? And according to WHO, it just says a state of well-being in which individual realizes his or her own abilities, can cope with the normal stresses of life, and can work productively or able to contribute to his community. And this has both biological, social, psychological factors that will determine mental health. And briefly, what is cancer? We all know what cancer is. That is abnormal growth of cells in the body. With cancer is non-communicable disease, and it's also chronic. And it's a life-threatening disease that it affects individual both at assessment, diagnosis, and treatment of the people, both the patients and their caregivers. Okay, we all know that in all this, we have accepted that both physical, psychological, and social issues can occur in over 30 to 50% of patients who have cancer. And we know that cancer have different types. From the physical point of view to psychological point of view, they all affect the patients and they will affect their quality of life. And so, oncology patients require both psychosocial, economic, and spiritual support to cope with their diagnosis and treatment. And the aspect of oncology care that can provide this very kind of treatment is called psycho-oncology. Psycho-oncology is a new area of care. It is holistic. It makes the whole care of oncology patients holistic because it looks after the psychosocial and social aspect of the problems of the patients, which are huge and which will affect the patients and affect the patient's quality of life. It is multidisciplinary in nature, and we have other groups of healthcare professionals that are part of this psycho-oncology. They are both psychologists, psychiatrists, nurses, social workers, nutrition, dietitians, palliative care workers, oncologists themselves, spiritual leaders, both pastors and imams. They are all part of this group of people who are going to help these patients to overcome whatever their problems are at that particular time and help them to look forward, help them journey with them along each stage of their diagnosis. And in order, the cancer care continuum is quite large. And you start by prevention, detection, diagnosis, active treatments, survivorship, palliative care, and end of life. And with these slides, I can even finish what I want to say. At even the community level, what is it that affects people most psychologically? It is anxiety. Even at community level, people are afraid to go for screening. Benga mentioned about it. And the worst off is even the doctors themselves, the healthcare professionals. For them to go for screening, people are afraid because they don't know what the outcome of the screening will be. And so even at that level, they need counselors, they need psychologists to calm them up, to listen to them and to tell them, no, you go for your screening. Early diagnosis is better than late diagnosis. You can do well once you are diagnosed early and you take your treatment, you can live a normal life. We can move at the dictation stage. Even when it is dictated, something is wrong there. Yesterday, I was in one of the secondary schools trying to teach the students how to do self-breast examination, to identify lumps very early. Even at that, they are uncomfortable. They're a little bit of distress about it. You need to encourage them. No, this is what it feels like. Identify it, then from there, we take it off from there. Once it has been diagnosed, the fear is there. They are worried about their lives. They are worried about what is the impact of this diagnosis on their life. Are they going to live? Are they going to die? What about their loved ones? What about the members of their family? What about their career? What about their life? Even at that point, you need somebody to listen to you. You need somebody to communicate to you adequately that, please, you need to go ahead with your treatment. At active treatment, which could be in Nigeria, surgical treatment, we don't have psychologists or psychiatrists actually helping the patients along the line of surgery, preparing them for surgery, preparing and helping them after surgery to cope with their treatment at that particular time. After surgery, there's chemotherapy. We don't have enough psychologists on people to talk to them about chemo, side effects of chemo, what they are likely to see, what is the outcome of it. Yeah, you may lose your hair, your color may change, you may have lack of appetite and all that, even at that stage. Even when they have passed through surgery, chemotherapy, radiotherapy, even at the stage of survivorship. Because one of the patients I met in Memorial Sloan Kettering Cancer Center told me that every year when she's going for assessment, she's so worried because she's afraid whether there's going to be any sign of cancer again. So every patient who has survived cancer during the time of assessment, yearly assessment, is also kind of anxious. You moved at the palliative care, you need psychosocial care even at that time, even to the end of life. You need all these things to be able to help you to cope and to enhance your life and to give you high quality of life so you could live and live maximally. Even if it means how long, because I tell my patients, who says, who knows? Nobody knows when somebody will exit the world. Only God knows. Nobody. And so there's no way, if you continue to be afraid, somebody who is afraid of death will even die because of fear, not because of the disease itself. And so what are some of the psychosocial issues in oncology patients? We cannot overemphasize the part that Our patients have emotional response to this illness. They are distressed, unusual feelings, which will bring about anger, which will bring about sadness, frustration, you know, they are tired, they are afraid, and some may deny that it's not even there. And because of all these things, they have poor coping mechanisms. They are not able to cope, they cannot even discuss, they withdraw. And some of the cultural practices, once it's diagnosed, that makes patients to come to the hospitals late. They will deny that it's not there. They will go from one place to the other, go to traditional healers. And some of these traditional healers, we keep them because this is how they feed themselves. This is how they maintain themselves. And they will not release these patients to come straight to the hospital for proper treatment, assessments, and treatment. No. Because of that, again, they are stigmatized. They stigmatize, they say, oh, for somebody who had mastectomy, he doesn't have breast and all that, is stigmatized and is not happy to come out. They discriminate against them. And some of these things make these patients to have, to be anxious and to be depressed. Some of them still may have their family problems. Some of them may have their relationship problems. Their husband may not understand what they're passing through. I can remember one of our patients ever told us in the clinic that even she's here, her husband does not know. Who is supporting her? She has gone for surgery. Her husband does not know. So she doesn't have any support. And you can agree with me that there's no way you will continue to cope well if you don't have any support, even family support at any particular time to help you. Again, like Dr. Bolu said, economic reasons bring these patients down. Poverty. Caring for cancer anywhere in the world is very expensive. And some of these patients, they don't have the money. Even when they believe they have to do this thing, but they don't have the money to pay for their treatment. And because of that, they may run away, they may not come on time, and they will be delayed. Again, maybe poor communication. Nobody has communicated adequately to them, and okay, this is what to do, this is not what to do. The doctors are trying, but they have a lot of patients, and they cannot say everything to one patient when they remember they have a lot waiting out. So they need help in that area. Again, that may lead to anxiety, poor social support, and some of our patients may have spiritual crisis. Is there God? Why is it me? Why is it that I'm the one that passing through all these things? Why? And we know that it may affect their cognitive changes in them. They may not recall quite well, and they start forgetting. It may also lead to infertility for some patients, especially some patients who have not started having their children, young patients who are not yet to marry. That may even lead them to suicide. They'll say, why? What are they living for? If they cannot get married, nobody will marry them now. And now, even if they marry, they may not be able to have children. Even some that are married already, they are at the risk of divorce because the husband may say, oh, I'm not interested. The family may put a lot of pressures on the husband, and that may lead to one thing or the other. There comes where the psycho-oncologists come. What do we do with this patient? We want to assess them. What do we assess? We want to assess the level of distress of the patients. And this is what we are saying, that in every cancer center, there should be somebody who can assess distress. We agree that we may not have psycho-oncologists, but the nurses could be taught how to assess distress in all the patients. Globally, this distress assessment have been accepted as 6 vital signs. There is temperature, pulse, respiration, assessment of pain, and assessment of distress. When you assess distress, you're able to know where their patients are. You will be able to know how the patient is coping. You'll be able to know whether this patient is within the care of the psycho-oncologist. We could use one therapy or the other to bring the patient back. If not, it could refer to a psychiatrist who can now include drugs to bring the patient up, and we continue with psychotherapy, But stress assessment is not universally done even in this country. After the stress assessment, we can do anxiety by using HERS scale. We can do mini mental status examination. We can look at if the patient has depression. After the HAND scale, we can look at depression rating scale, anxiety rating scale, coping mechanism, stigmatization scale, and spirituality. This is a diagnostic instrument which a clinical psychologist can use to assess the level of distress, the level of anxiety, whatever the patient is faced by at that particular time before giving the treatment. We use NCCI distress thermometer to assess distress. And this is a paper and pencil scale, which we have divided into two. It has non-distress and extreme distress. And generally, we agree that there's nobody that is without stress. There's nobody in the world. We need a little bit of stress, which you call eustress, to live normally. And so when it's above 4, you will say, oh, these patients are between 4 and 7 scale. In the scale, they'll say, these patients, psychotherapy, talking to this patient can help the patient cope. But by the time it's getting to 8, 9, 10, you may need the help of psychiatrists to help both the psychiatrists and psycho-oncologists continue in helping this patient. Again, the patient can look at where is the stress coming from? Is it from family problems? Is it emotional problems? Is it spiritual problems? Where is the patient? Where are these stress coming from? And with that, you'll be able to know what kind of psychological treatment that you could give to these patients.
Prof, can you round up for us now so we can ask some questions?
Okay. In psychotherapy, we have individual psychotherapy, we have group psychotherapy, we have cognitive behavioral psychotherapy, we have distress resolution exercises, realization exercises, a lot of exercises, psychotherapies that can help these patients to cope and increase their quality of life. We can also use guided imagery, thought distractions, communication skills improvement, support group, good communications, psychoeducation, dignity therapy, meaning-centered psychotherapy, and family-focused therapies. Okay, thank you.
Thank you.
Yeah.
Thank you. Thank
so
you.
when we are asking the questions, maybe we can bring out more.
Yes, hopefully. I'm trying to get us all back on the screen so we can see each other. Are you off now?
Yes, I'm trying to. Yeah.
Okay. Okay. So thank you. A round of applause to our 3 speakers. I want to say a very big thank you to you all for sharing, especially as we look at this and recognize that, wow, your work is very different. I can actually come in from that. I don't know anybody else who is on the platform who has been through or is going through this journey, but some of the things I've heard all 3 of you say is quite interesting because it is real and I can identify with them, but so that I don't also probe. Anybody that has questions, please can you start sharing your questions? I'm going to start with one question that really does bother me, and I hope that other people will be able to put in their own questions as well. So first question, and who is it going to go to? Okay, let me ask the question first, then maybe it'll work from there. One of the biggest things that has come up continuously for cancer patients, and I'm looking at it from my perspective, is when you are diagnosed, we get confused, totally and utterly confused, because it is still, no matter what anybody thinks, it is the C word. And when something is the C word, how to move past that? The C word automatically is mentally, it's in the world, it means you're dying. Now, I know it's not supposed to mean you're dying, but that is the first reaction of anybody who is diagnosed with cancer. So from all of you, because you've all come from it from different perspectives now, so that works. And I'm going to start with Dr. Bulu. If somebody is diagnosed with that, can you give us 3 things that we need to just try and get right very quickly to help us to? I'll say from my perspective, I actually shut the world out. Only my family were involved, and it was just my direct family, my siblings were involved, and my children. Can you give us 3 things that we need to just do right. Maybe that will help our mental state align in the right direction.
Number 1 would be get the correct information, all right, specific to the cancer, because that often is the problem. People have misinformation. Number 2, that's the time to set the treatment goal, which should match expectations, all right? Once you've been diagnosed, an initial meeting should be held with yourself, the carers, and those relevant people to outline what is your treatment goal, because oftentimes your treatment goal doesn't match with the reality, then there's a problem. The third thing is, if we had that, early involvement of support groups is very crucial. If we're able to do these 3 things, correct, the appropriate information, treatment goals, identify treatment goals early, long-term, short-term, medium term, and then early involvement in support groups. That's what I would say.
Same question now goes to Gbenga.
As Dr. Ugbolu said, you know, when somebody's diagnosed with cancer, you know, everybody is going to be different. You know, it's not going to be one heart fits all, because there are times where somebody was diagnosed with cancer, and then they went to see someone else, and it wasn't cancer. You know, but the first thing is, you know, when you hear that diagnosis, you know, hopefully, you know, that person will have somebody close, maybe their spouse, maybe their parent, maybe their children. Because the first time you hear cancer, even doctors are humans, and, you know, I've seen doctors, you know, diagnosed with cancer, and they just broke down. So we're all human beings. But the first thing is, you know, that diagnosis, you want to confide in someone. That's, you know, the first thing. You know, if there's a problem, you want to, you know, of course, you want to take time to like let it sink in, but you want to talk to someone. Doesn't matter who. Because the more you talk to people, the more you're letting things out. You know, mental health, everything is boiled in you. So the first thing is, you know, you need that avenue to talk things out. And then, you know, of course, if, you know, if it's confirmed that it's cancer, then hopefully, you know, you have to ask, you know, questions. You know, everything you're thinking about, you have to ask, you know, professionals, you know, your doctor, you know, is it going to kill me? You know, because nobody wants to die. So, you know, you have to keep it, you know, is it going to kill me? What should I do? And stuff like that. But the bottom line is, if you, you know, if an individual has cancer, you want to be part of the whole treatment. So that's,
I'm going to go to Prof on this one, because based on what the 2 of you are saying now, Prof, let's come back to the drawing board. Because in Nigeria, okay, let's put it in the 2 spaces, right? Because I luckily have the advantage of being treated in the UK. Now, the mental health system in Nigeria, the everything you require, we already have accepted, but all of you have said that there is not enough people to support the network of people that need help in this area, right? Professionals. Okay, so if there isn't enough, what are the priority stages that would what are the things that will make a cancer patient prioritize to be able to get at least the basic help they need mentally? Because the reason we're able to be deceived, I would say, let me use the word deceived, but it's not deceived. The reason we're removed off track is more because everybody else seems to know what's wrong with us than us that have the disease. And until we are allowed to take control, we are not in a position to mentally fight it. And so from where you are coming from, how does that align? Because it has to align for people to be able to fight this disease. And I'm talking about it from a perspective of someone that lives with it. Prof Choma, are you still on?
Where you are coming from, all right? Yes, I'm on. Are you?
Yeah, I can hear you now.
Yes. When people are diagnosed from what you have said, that you are not allowed to take proper control or contribute meaningfully to the to identifying the objectives of your care. Do you understand what I'm saying? You are not part of the decision-making process, and which I think you should be. Because I believe over there, you are told you are going to take this. What do you think? And you are part of the meeting.
Yeah.
Aha. Are you getting what I'm saying?
Yeah.
But here, because they have people and they have time, but here, they will explain to you, this is this, and these are the options for you. But I accept that you need to be part of that decision that, yes, I've understood this very thing, and I want to take it this way, that way, that way. And so you need time to convince yourself that this actually is your diagnosis. You need acceptance on code, that, yes, this is this. But that does not mean, when you say, people will say, no, I'm not accepting, it's not my portion. That's not what I'm talking about. You need to accept, yes, this is this, and this is the treatment plan to deal with it.
Okay, thank you.
Yeah.
Anybody got any specific question they want to ask? And I will just unmute you to ask your own question before I continue again, because I got one other question sitting here. Is anybody with a specific question?
I have a question for Dr. Ogbolu.
Okay.
So if I can, ask a colleague a question. You talked about suicide, and that's something that, of course, I rotated through psychiatry, and one of my colleagues is on the Zoom meeting, but I'm just going to call him Skin. He knows himself. Anyway, suicide, because, haven't been here since 95, and I read in the newspaper, people want to commit suicide and then they lock them up. So when you talked about the fact that, suicide something organization in Nigeria, I'm thinking, how do you deal with that stigma whereby somebody tries to jump from the Lekki Bridge and then, the police will go and lock them up? I couldn't believe that, people are being, sentenced to jail for committing so I really want to know how you're trying to fight that. So that's my question.
All right, thank you. Again, you're right. It sounds senseless, really. Let's be honest, that somebody who has some psychological problem or psychosocial stressors attempts to end their own life and then has to be sent to prison. The law says 12 months imprisonment. Okay, so and that's crazy, but that's the law that subsists. Okay, Nigerian Criminal Code. So we have to get around that. And one way to get around that is to, one, amend the law, and then two, to have a mental health law. So we have a mental health bill that has passed through the second stage. And last month at National E-Conference, SOFPIN, the Senator Lori Egbe, who was the chairman, informed us, because he's leading the drive to pass the mental health bill, that it's passed the second reading. It's not likely to go through the same thing in the House of Representatives, so it should be passed. So that's one. That will help us. So what do we do now when we have such cases? Even the police understand that it doesn't make sense. So when we first started something, what we did was to involve stakeholders. And so we got the police involved. And they understand most of the time when they do see cases, they would call, because they understand that, look, this person could be going through a psychological problem. A lot of times, so what we would then do is go to the police station and ask them to release this person to us. Now, to do that, we often have to work with a legal NGO. So they would go approach the court. Recently, we have one currently. He's been just about to be sentenced to prison for attempting to end his own life about 2 weeks ago, yes. So what we quickly do is we notify the NGO called CHEL. They are involved in legal aspects. So they make a presentation to the court. Then once the court hands the person over to them, they bring to us. So that's what we do for now. So we work with the police and then this NGO until we're able to get those laws, dismissed and then the mental health law passed. So it's funny, but at least we've got so far quite a lot of cooperation from the law enforcement agents.
Thank you.
All right.
Thank you. The next one is Wale. Wale has his hand up. So Wale, you can put your hand down, and I'm asking you to unmute yourself now.
Oh, hi. Thank you all. Oh, this has been very educational. I have a couple of questions, but the first one is to Wenga. I'm not sure what comorbid conditions are.
Sorry
So the
for,
question is, what are comorbid conditions?
sorry for using the medical jargon.
No,
Comorbid
it's all right. It's okay.
just means other things you have. So somebody might have cancer, but do they have depression? Depression is a comorbid condition. Do they have hypertension, high blood pressure? Do they have diabetes? Because some medications also have adverse effects. So you can imagine someone who has diabetes, high blood pressure, and then they have let's say gastric ulcer, and then they now have cancer. So they have 4 things. So apart from the cancer, they have 3 other comorbid conditions. So it's just going to be more. So that's so comorbid illness just means some people call it comorbidity, but it just means all that associated illness. That's what it means.
Next. Wale, your next question.
Oh yeah, this is, I think, more appropriate for Dr. Asuzu. I can only speak from my own personal experience with my mom. When she was diagnosed with cancer, and in Nigeria, I have seen that the doctors tell you exactly what they think and give you instructions on what to do. But here now, I'm just hearing different, very interesting things of how it should be, which is to involve the patient, carry the patient along, and involve other stakeholders as well. But as at that point, when my mom was diagnosed, it was only the doctor, and he just said what he said, which was she needed palliative care, and that was it. There was nobody else. And this is the head had looked at that time. So the question then is, how is it in Nigeria now? Are they able to involve other stakeholders? Because from all you have said, it is critical for any cancer patient.
Now the doctors try to involve other people. The nurses are there. They may not have all the psycho-oncology psychiatrists, but the nurses are there. They can do 1 or 2 things. They can talk to the patients. They could discuss. For instance, in our psycho-oncology unit, every Tuesday, we run a psycho-oncology clinic. First of all, we talk to the patients about their psychological state of mind. We prepare them before they go to see their doctors. And they are able, we equip them with confidence and skills to ask questions from the doctors. Because the doctors are busy. If you don't ask them certain questions to let them that, I know what is happening, I want you to answer some of these things, because they are in a hurry, they may not. But when a patient also engages the doctor is able to relax, and he may say, I refer this patient to psycho-oncology unit, and after or social workers or things like that. Yes, we try to integrate it. It may not be so in all the centers, but they are trying to integrate it. And one thing we are sure in this world is change. And there is a lot of change going on even in the curriculum of medical students, of the doctors, and they want to do a lot of our psychology in whatever you are doing, to be able to help our patients, to give them quality of life, the stage of their cancer notwithstanding. Thank you.
May I just quickly there that, I mean, again, it also involves us educating our
Yes.
colleagues. And that goes a long way. And I think in our individual spaces, we need to continue to do that. And just to highlight what you said, I'll give an example. Still part of my work as CL psychiatrist, I would oftentimes go to see a lady who has had a stillbirth. And I go to the ward and nobody has informed that they've just taken away her baby and she's just there. You know, so it took me explaining to colleagues that no, you need to carry this person along. You should even let her hold the baby, name the baby, if possible, mourn the baby. And because those things are important for her future mental well-being. And then some of them began to incorporate it. So it's about some not knowing, we need to tell them. So that will help to, change these things.
And I want to quickly add here too that Psycho-Oncology Society of Nigeria, IPOS, International Psycho-Oncology Society, like last conference in AUTI conference in Mozambique, we try to teach communication skills to oncology practitioners. Because this is a skill, you need to acquire it, you need to know how to communicate diagnosis, you need to know how to communicate illness, you need to know how to tell patients about their treatment, the side effects. It's a skill that I want every oncology doctor, or every doctor to acquire. It's very, very important. And Psycho-Oncology Society of Nigeria and International Psycho-Oncology Society are trying very hard to make sure that we run these workshops and training for doctors.
Let me just say something.
Thank you. Okay.
Let me just piggyback off that. I'm talking about, how to communicate. No matter what you want to communicate, if you don't communicate empathy to your, to that person, nothing matters. You can talk about the, stage of the disease. You can talk about their depression. You can talk about everything. But if that patient doesn't feel that empathy from you, it means nothing.
Okay, thank you, everybody. Is there any other question? I'm just trying to check. Any other questions? Okay, Wale back again. Wale, this is your last one, Ru. Go on.
Why now? You do Pasha?
I know they do Pasha now.
No, yeah, this is from our point of view now. So this goes to the three of you. Thank you once again for your time. So how can and should CCF help in these areas that we've just raised?
CCF is Commonwealth Cancer Foundation.
Yeah. Oh, sorry.
Go on. Who wants to start? How can? Well, let's say it again, please.
How can and should the Commonwealth Cancer Foundation help in these very critical areas that you have raised?
All right. If I may go, one, I mean, as Denise mentioned in the beginning, we have a lot of dealings together. And one which we recently talked about, which we will pursue, is how to work together, CCF and SERPIN, okay? So that's one thing. Collaboration is very key. The other thing, we've talked about the fact that, especially the first question that Denise asked all three of us, you see, it's a journey. And how you set out on that journey is very important. Now, unfortunately, to many people who do have cancer, just like some other conditions really, you don't know, you can't, at the beginning of the journey, you don't know how long the journey is going to last. And you don't know, you can't say this is where your last stop is. So that initial bit of it, I think that CCF and the Psycho-Oncology Association, which Professor Asuzu mentioned, because we don't have enough people in the hospital physically to help provide, I go back again, for me, information is key. It starts from there. Because when you know, when you have the correct information regarding what you have, It's a thing that CCF and the Psycho-Oncology Association will have leaflets, information leaflets designed for, we can start from the hospitals in Nigeria where cancer is treated, explaining some of the basic things we've talked about today, because these are the questions that come to people's minds. We have that, outside of, abroad, this is very common for every condition. As you're being diagnosed, you pick it up there and you read. Before your diagnosis is confirmed, you've read about it. So I think that's something that could be work. It will be a big project, but let's have enough information leaflets. And because the information leaflet can never answer all the questions, there must be a line, a number people can call for follow-up questions. I think that will help us set out on the journey on the right footing. That's what I think.
Can I follow up with what Dr. Ogbolu said? So there's a saying, and I'm not trying to, use any derogatory word here, but they say, monkey see, monkey do. I remember when Obama went to Kenya, and a US senator, and he went, to the side street and, had to, check himself for HIV. And just that single intervention helped the whole country for everybody to start testing. So what am I trying to say? Because we're all Nigerians here. Mental health, the stigma is just huge. And, God bless, my colleagues, practicing back in Nigeria. It's, the stigma is huge. It's like mental health, you're crazy. No. So I think, one has to continue to put a face. And I'm not sure how CCF can do that. My childhood friend, Larry Tejo, we went to Gobi together. He was the chairman of Senate Health before the new guy who is there now. And we had tried to do something about mental health, but somehow he didn't win, so, he's now doing more of telemedicine. But I think, there has to be a way, because when you involve these decision makers, Femi Gbaja, is a very good friend of mine, he's a speaker. But you need to involve people, because when, if someone has cancer and they come out and they say, I have cancer and I'm receiving treatment and, blah, 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 depression and all that. And the people at the bottom see that, it does something. So I'm not sure how CCF can get, the big people. That's what we say in Nigeria. The big people have to be part of this somehow. Somehow. I don't know. But because they have to buy in, and as Dr. Ogbolu said, it's going to take time, whereby, maybe medical schools will start teaching, that approach, that multidisciplinary approach, that, it's not just cutting the patient and letting them go. Somebody has, still bath, puerperal psychosis, it's going to be there. So you must be preemptive, you must be aware of what's coming. Because if someone has a child and that child dies, that lady, she's not happy. She doesn't need to tell you. So, but with time, we're going to talk more.
Okay, I would like to also contribute to that by saying that we could collaborate in the area. I agree completely with what people have said about information leaflets, about getting the big people, as they said in Nigeria, to be part of what we are saying. We call it here at giving political will into what we are saying. That's the way it could be carried, political will. But I will also add to what you have already said, that we also need to do something like catch them young. We have to desensitize the word cancer even to the younger people. Let the young people know about what cancer is. There's also childhood cancers. Let them know how it could be prevented. Let them talk about it to their parents who cannot go for screening, so that it is not the word everybody is afraid, run away. No, it's something that we could tell the young people what you could do as a young person. This is how you could prevent it. And with that, we all have it in our minds that we go for screening, that a young woman who is sexually active, we go for pap smear, and that people could go for other things like that to prevent this cancer before they start seeing signs and symptoms of cancer diagnosis. Thank you. I'm not hearing you again.
We can't hear you.
I muted myself. I think it's just a habit. Okay, I just want to say a very big thank you. And yes, I did have a chat with the Prof yesterday about this, especially catching them young, and trying to see how to see where we can work together in a partnership where I can access education. So if the specialists bring what they're bringing, then we will try and work it together, because that is actually honestly the way I work with SERPIN. Dr. Ogulu and I am not in the medical profession. I sit on the board with them, and all I say is, excuse me, from the children's perspective, and they answer me on that one. Excuse me. So it's okay. And I think sometimes we always need to learn to stay in our own lane. There are a few hands up. Hold on a minute, but I want to just read out. There's a question I have here that is very interesting. At what point should children be informed if their parents have cancer? And what support is available? Sorry, who's going to help on this one now? At what point should children be informed that they have cancer? Now, if I say from my perspective as a parent, when I got diagnosed, I informed my children myself. And we agreed to work it together from the onset. And they were not allowed to be afraid because I was not going to be afraid. So we were going to take each day as it goes. And every time we do something and I say, we're going on holiday now, I've just had a surgery. And they would say, is there something you want to tell me? And I'll say, no. But every day is now worth more than what you think. So I'm not sure, based on this statement, other parents, because I do also know in the same conversation, a lot of, at least one person online here, I don't know if she's still on, nobody in her house knows that she has cancer. And she's gone through the treatment and nobody knew. And she had gone into depression. So it worried me, and now we're okay because I've told her that, they say, I can't do this, I can't do that. I say, you can do everything. You better just do everything and enjoy your life, because you don't know if you're going to be here tomorrow. But that's a very good question. At what point? Because all of us take this thing, you know, the C word is the C word. Let me just put it like that. So who wants to answer that one? I've got 3 questions. And Juliet has a hand up, and somebody by the name of Arowojo, I don't know, that is very interesting, has a hand up. So I'm going to take them after. Who wants to answer this first one?
I can take a go at that.
Okay.
I would say that at the point when you find out that the child is ready, and how will you know that this child is ready? It depends on so many things. If you know the personality of your child as a parent, is your child already genetically very fearful? Is this child very emotionally attached? Is the child ready for, all your children, you will know, if you look at it, you will know their personality dispositions. You will know which one you will discuss certain things is okay. You will know the one that is more on the emotional side. You will know the one that is, so, and you can start gradually, you know, not in a flooding manner, in a desensitizing manner, to let the child, are they ready? If you are going to the hospital, your children will not ask you, you stay there, will not ask you. It depends on what kind of family. You people have not been discussing right from the word go. But if you are a closely knitted family, you have been talking, you go away, you tell your children, I'm going to this place. Of course, the children will ask you, and you have a right to explain to them. And after explanation, you have a right to give them confidence. Like I think you are giving to the children, it's well, I am going this, and you people will take the decision together during the process of explanation, communicating to you what the illness is, the process of it, the treatment of it. Of course, you are all part of it. You will see that these children are ready, and they will be doing their own parts. They will be praying for you. They will be doing your own, and you will be doing. They will be doing their own. You will be doing your own parts. So that's my own.
I think I will agree with you on that one. On that one, very clearly, I totally and utterly, because my youngest child at the time was in secondary school, and we didn't say anything. I let her do everything, and after every surgery I had, even my last brain surgery, I didn't say anything to her. I waited, and then as soon as I finished in the morning, I said, please give her the phone. She was in Nigeria, I was here, and I said, I've had my surgery. She said, why didn't you tell me? I knew you were doing something. I said, yes, but you are in school, so you don't need to be, at least I'm alive. That's all that matters. And I'm talking to you, say that. So say, can I see you? I said, yes, and I put the camera, and that was it. So I think, in all honesty, I think parents should really try and trust that their children can take this on, because it's not very fair. If anything is not the plan, but if it's time to go home, then your children are broken because they didn't have enough time to spend. Anyway, the next one says, even though I have been told there is no evidence of disease, that is, I'm sure somebody who has actually gone through it and come out, I still struggle with grief and the why me. My question is, how do I deal with the grief that hasn't gone away since I was diagnosed? Dr. Ogulu, I think you're going to be the one to help me on this one, don't you think?
Yeah. And I think Benga mentioned it. Talk to someone. Now, grieving is a process, all right? And while you cannot change the reason why you've gone into grief, you can change how you deal with it. You can control how you deal with it. And it starts from talking to someone. So, because again, you don't want the grief to become abnormal grief. It's okay. Grief is a normal reaction. So that's the first thing. You don't feel guilty about feeling grief. It's a normal reaction. It's how you then deal with the grief, because you don't want it to become abnormal grief, and then depression and other things set in. So I think a simple thing to do is talk to someone. It could be someone who is non-professional, and it could be someone who is professional. If you can talk to both non-professional and professional, very important.
Mr. Arowo Job, you have a question?
Before that question, I want to add to the other. Okay, I want to add to the question on grief. And I think the person needs to see a therapist, a clinic. So she may need a CBT to remove that cognitive error, something to replace it. Because if something have gone to abnormality once when it's supposed to be a normal thing, then you will need a therapist to help that person to come off it.
Okay, I will privately try and get through to the person. Please, whoever it is, I don't have a name. Can you please get in touch with me? You can go on to Commode Cancer Foundation messages and just give me a back end message, please, a private DP, please, and then I will send it to the right person. I'm not a specialist, and we don't work from that perspective. We'll help to link you up with who can help you. I'm not in a position, but I can help you link up. So if I have to get you to Dr. Ogulu, I will get you to him and he will answer you. Trust me on that one. So yes, Mr. Arowo Job. Sorry, I'm having to use that because that's how your name comes up on here, yeah?
Well, I forgot to write the E at the end. It's Arowo Job.
Okay.
Okay, fine. I'm going to comment first on about the. I want to ask a question, but I want to comment on your question in relation to when is the best time to tell a child. I think a child should be told as soon as possible, really. I say that because, you know, having cancer might be a silent killer. One might have that diagnosis and it might not be obvious. But what about if a parent is involved in a life-changing, traumatic road traffic accident? Can that be hidden forever? It cannot. So a child will know that immediately. Now, my real question is more about what Prof was saying about catching them young. And I'm kind of wondering is about what are we being taught in medical school and schools of nursing? You know, because it seems that a lot of times we forget that there is a very significant relationship between mental health illness and physical health illnesses. And that physical health illnesses is very likely or most commonly to manifest as a mental health illness. And the other doctor who spoke earlier on, kind of highlighted the importance of having psychological input in hospitals, for physical health, where you can have a a psychological assessment of one's mental health in reaction to whatever physical health diagnosis one has. That's what I want to say. Thank you.
Thank you. Who did you direct that question to? Was that not to Prof?
It wasn't much. Mine was more about when Prof was talking about catching them young. It was a contribution about medical schools and schools of nursing need to be kind of taught more about this. That's where we can catch them young.
Yeah, I was going to. I've actually put a note down based on what we've talked about today, and that says that, Prof, I'm going to come back to you because there is actually a serious concern about curriculum content in Nigeria on a lot of issues. Some of them are dated and some of them don't exist. And they need to exist because the world is turning around. But you are in the sector, so we all have to use our heads together and enter places. Like Dr. Ogolu here, you may not say it, but that's our last document that we're waiting for the Mental Health Act. It's gone a long way and they've really run around for it. So whatever strategies or people that have supported in getting that through may be able to guide us in the right direction to get other things through as well. The next one, and I think that's going to be the last one, was Juliet has a hand up. So I'm lowering your hand now, Juliet. What do you have to say?
Okay, I just wanted to say such a great thank you to the panel. You've been really excellent with talking about mental health. I personally had a son who was very young and went through a bone marrow transplant. So a lot of the stuff you spoke about, I've been through a lot of them. I just wanted to just thank you and then just raise some point about, one, the stigmatization with cancer. My son didn't have cancer. He had something different, but had a bone marrow transplant. But I find that with the stigmatization of cancer, not just in Nigeria, even here, Black people don't talk about it or tell their families about it. And it's so important that people get educated. I mean, where I work, cancer, it's not a big issue because in a team of about 20, we've had about 10 people who have members of their families or whatever who have cancer and talk about it or go for treatment daily. So we need to break that stigmatization. You spoke a lot too about the consultation and holistic, which you have to think, talk about the diagnosis and the person, their mental health is so key. So what the doctor was saying about distress assessment is so important so that the person has a whole holistic treatment. It's not just their treatment, it's also their mental health and how they address it with their family. I also, in terms of telling children, you're quite right. My son was young, I had 2 older children, and we thought we were protecting them by not telling them the full impact of what was happening with their brother. And we learned that you do need to tell them and tell them early. Children know when something's going on. If you give them the facts, they can work with it. Also about education, when I started with my son being ill, I didn't know much. There was consultants telling me stuff and whatever. So I had to learn and educate myself and ask them questions. You're quite right, here in the UK, it is quite interactive. They talk to you and they tell you about treatment, but you can also challenge that treatment by learning and asking questions. So I think that is so important. You raise so many things, and support groups. So we had to set up a support group too, because I was in a team with different women who had children going through bone marrow transplant for different things, cancers. We all had different things, but we did set up a support group, which was so useful because we could talk to ourselves and help each other and reassure each other. And we learned so much. And this is 5 years on, we still talk to each other and support each other. So I think it's important that we try and break the stigmatization of cancers or any illness, because if you educate people early with cancer, if you find it early, a lot of it can be treated. So I thank the panel, they've done an excellent job. We need to educate people. And I think children, if we can go out to schools and start educating the younger generation, they are more resilient. Parents are constantly trying to protect people, and I think that might be a way forward, educating our younger generation with and letting them know that there are solutions to cancer. Cancer doesn't kill all the time. If you find breast cancer, prostate cancer, if those things are diagnosed early and treated, one of the doctors talked about he used a frame about the passive suicide where people are in denial and don't want to deal with it. We need to just educate people and let them know that cancer doesn't kill you all the time if you do the right things. So that's my input. I think the panel have been absolutely excellent today. So thank you. Thank you, Denise. Thank you for your
I want to thank this panel, actually.
Yeah.
You've been very informative, and actually mental health is something that is very dear to my heart. But also in the same conversation, just before we end, I want to do a tribute to my mother, who would have been 81 this year and is late. So her birthday is actually on National Mental Health Day. So I have a tribute I'm going to share screen on now for everybody. I think it's 1 minute.
You walk through a storm, hold your head up high, and don't be afraid of the dark. At the end of a storm, there's a golden sky and the sweet silver song of love. Walk on through the wind, walk on through the rain, for your dreams be tossed and blown.
Hello, my name is Francine Edjo, and I am a granddaughter of Mrs. Margaret Ann Edjo Nee Cormod. Cormod Cancer Foundation was created in memory of my Nana. Nana was an educator and an enthusiast for making a difference. Nana had an impact on strangers, myself, my siblings, my cousins, and even students, because Nana was a teacher. Today we celebrate Nana's birthday, what would have been Nana's birthday. My Nana died 5 years ago on October 30th, 2015. Although today would have or should have been a sad day, it is a cause for celebration because Cormod Cancer Foundation is now a reality. And as we embark on this journey to spread cancer awareness, we hope that you will join us to make a positive influence worldwide. Thank you for watching, and we hope you enjoyed the session.
All righty. Thank you all for today. It's a very special day for me, and I am very grateful that all of you were part of it. And we hope that we'll continue a partnership together with everybody going forward on how to drive change in Nigeria on cancer care. Cormod Cancer Foundation, for those of you who have been part of this, I will ask you for your handles so we can tag you onto events that we also do going forward. Any questions, please use our Cormod Cancer Foundation Instagram page. Our website should be up and running anytime now. And the videos will be going onto the Cormod Cancer Foundation YouTube channel, which is almost ready to, is being loaded up with all our videos now. This will be out on the platform anytime soon. So I want to say a very big thank you to all our speakers. Wenga, thank you very much for your time. I thank you for waking up very early. He's in America to be here, to be on this platform. Dr. Ogbolu, you know, I'm still coming back to you. You gave me assignments, I will do it. Thank you very much for everything that you are doing. Prof, I will still come back to you on everything that we have to do because we have to make a difference. And to be honest with you, I think children need a lot of care. On behalf of the Board of Directors, Board of Trustees, Benga, thank you for actually being one of our Board of Trustees as well. I want to say thank you for all that you are doing. Thank you for being with us and thank you for supporting us and giving us the courage to go forward. I say, have a lovely day, have a lovely weekend, and I will see you all soon. In the next 2 weeks, we have Breast Cancer Awareness on the 24th, which is Breast Cancer Awareness Day. See you all, and thank you very much. A round of applause to my house. Thank you.
Thank you.
Thank
Bye.
you. Bye.
Thank you very much for doing this, Denise.
Yes, thank you.
Thank you, Denise. That was a great session. Thank you.
Thank you.
It was a very good session.
Yes, excellent.
Juliet, your comments were also well spoken from an outside perspective, because you can hear the experts. But when you hear someone who's gone through it all,
Yes.
it's always very liberating.
Thank you, ladies. I got so
Thank
many
you, everyone.
ladies here.
Well
that
done.
I didn't even realize.
Denise.
Wow.
You're making a difference.
Yes.
Keep it
Well
up
done,
and
Tulu.
don't give up.
She's saving lives, Tulu.
Yeah.
Yeah.
You're
Really?
saving lives, Denise.
Really?
Of course
Yeah.
you are. You're talking
You are.
about it.
You are making
are.
a difference.
Yes.
You've got
We
to
You are
keep
need,
making a
talking about
we need
it.
this, Denise.
We need
Yeah.
this to dispel the taboo word.
Yes.
The taboo word.
Yeah,
It is
people don't
taboo
say
word.
cancer. They say the C word. Come on, this is 2020. It doesn't kill. You're making a huge difference. You're saving lives, Denise. Keep up the good work. You know?
Digital workshops like this would help people learn about it. Digital
Yes.
workshops. Even we could even take this Commode Foundation could even take this to the pidgin language to get through to the people, the masses in Nigeria, so they know that's who they have no information at all. They will see a leaflet, but they won't read it or can't read it. So we need to get this word out. Like Big Brother Naija, we need to spread the cancer information out.
Mm-hmm. Yes, is that you talking?
That is totally your cousin talking, darling.
Listen, how come you woke up early in the morning? Sorry, thank you. Thank you for waking up early.
No problem.
America.
So that last comment is actually important. I did want to say it. I think you should think from Commode Cancer perspective. You should think about campaigns that can be done to bring awareness to people. People wouldn't read leaflets. Leaflets are a good idea for those who can read it. But campaigns, video campaigns, or whatever campaigns that can be done, like advertisement campaigns.
What we're going to do is now we've eventually got so those of you on the platform will know we've got quite a lot. Wally is working on it, a lot of stuff, and we're putting them all up. So we're going to try and start with what we've got, and luckily this half year, this June time we started all this. So we've got quite a bit now. We've got I think we've got about 8 videos now can be shared. So at least people can watch it and see it's reality, it's real. We're not being patronizing, and hopefully we'll put a plan together based on everything we've got now for January and start to go. But the main campaign is things like billboards in Nigeria that's sticking in their faces that it's real. So, but any states that we have a billboard, I would want to find the cancer center next to it. So if it's like in Abuja, I know National Hospital has a place. No point having the billboards without a link to where they can go. And billboards in Nigeria are very expensive. So I want to see if I can get
radio. What about radio?
What about radio? Exactly.
Radio is not radio. We will get that done, but I would rather if we did radio, it goes into radio pidgin. And yes, but what I'm saying is that but it's not. Okay, but for instance, now I can't raise money even sitting here. I'm not able to raise any money sitting here. I have to get to Nigeria, because even if you're asking people to fund anything, unless they are looking at you and looking at them and you say, please write the check now, you're not going to get anything. So until I can get into that space,
Well,
and
we can.
COVID has locked us out.
Yeah.
COVID has locked us out, and until I can get in there, because everything we're talking about requires funding. Most of the people that actually work on the platform now are working on goodwill and support. That's it. And
You can harness the power of social media, Twitter, Instagram, Facebook. I mean, a lot of people in Nigeria these days have Facebook. Share it with one person and ask people to share it.
Yeah, but you
share it via
that,
WhatsApp.
That's people will say they will do it, they don't do it.
All it takes is, let's try and make a viral video, a video campaign. Let's talk about cancer or something.
Yes, and that is why we've got the videos of the Commode Cancer now are going on the YouTube. And in that one, I'm going to do a talk on that one very soon, anytime this week, and get that now live up and running. And maybe they will put it on all our social media platforms for people to see. And then because we're now taking the links to tag people that work with us, and people tag themselves on the social, if people tag themselves, then the messages go out. But people have to tag themselves. They just don't want to tag themselves. A lot of people that have actually don't want to talk. They don't want to be identified with it. They don't.
Your story, Denise, honestly, your story does just make a lot of difference. I've mentioned you so many times to my friends all the time. I talked about you to my friends, and they go, "Wow," and they go all gobsmacked. Honestly, just 5 seconds of your story in any of the plugs that go in will just do. You know, when you showed your picture with the whatever knife on your head, it's real. You've gone through it, and that is liberating. I'm just giving ideas for you. I know
no. I know now. I come and I banter with you. You have lyric from me.
So I know you would come up with, but I'm just suggesting that, you know, those videos that you're doing, maybe you can just combine them, just do a small short video with a few statements about yourself. You be in the face of it, just a few, 1 or 2 pictures of your experience.
What I may do is use the way
people's attention.
Wale is online, he's listening, so I'm very glad he's listening to all of this.
Yeah, that was on purpose. Tolu, that's absolutely brilliant. I've been trying to sell that idea to Denise for a while. And I'm
but we agreed now.
Hold on. Yeah. I mean, from me, you know, it's different. I'm glad Tolu is saying it. The idea is that we have now managed to get, I think, 8 with this one today. When we do it with 9 videos, but for the front, it has to be Denise's face, and she will sell her story. That's the idea. How she does it, I'm just hearing for the first time this one. You are saying she has a picture with a knife, so we have to sell it.
I know you were not on that event.
No, so so I stayed back on purpose just to catch ideas of what you ladies are talking about. So it's brilliant. Yeah, I was eavesdropping.
That's fine.
So I'll put all of those on the website. So that's brilliant. Yeah, and about the campaign, that will be the root of the campaign. And we will link that to the website. We will link it to the, I will automate it so it's loaded onto the other social media platforms. Like we have a Facebook page, we have a Twitter page, I think. And there's one Instagram one as well. So the rest will now be in you guys' hands just to spread it.
So I think the other thing we can do is share I'm not very like onto Instagram that much, but we'll share our details, Instagram, Twitter, whatever, Facebook. So then when, like Denise said, tag us. Then once we're tagged, we tag people. Here's, let's talk about cancer, especially as breast cancer is coming up. those are when you have these significant dates in calendars that people talk about. Those are the times when you can actually press in and share videos and share things with people in commemoration of these things, and so that people can then retweet, send it out to their circle of friends, and so on and so forth.
Indeed.
Social media will do this campaign better than anything else.
Yeah.
Okay.
Yeah.
Absolutely.
And also educate people in our community as well to talk about
Yes.
it.
Okay, but what I know we will do, I mean, I trialed out this video of my mom's tribute. It was produced between all of us. Wale, did you see I got pictures?
Yeah, Angie told me.
No, so all those pictures now you can have. You can now have all of them. So you can do as you like with pictures. Wale has been getting frustrated, lack of pictures. Okay, I've got pictures. Angela, what are you doing here? I'm having a chat. wait. Anyway, I will do a video like that, like 2 minutes. It's not even up to. But we have to make sure, because there cannot be, there's a number of minutes it can be for it to run, for you to see it, for you to want to watch it.
Yeah.
Yes,
Because if you put a
algorithms and
video,
things like that.
yeah, they have got rules, because if you put one
1
on
minute.
Instagram, something like that.
Yeah, 1 minute, but like
1 minute,
the
just a quick one.
The first thing is the picture, the grabber. And the next is then is the grabber, the picture, the headline, and then just a few, like a sentence or two.
Yes, I'm a survivor of cancer.
Thank you.
That picture.
I'm attending something
That
at
picture.
4 today, and that's what it says. I'm a survivor. That's all you need to say.
Yeah, I'm a survivor of cancer. That picture, I'm still alive. That gives
Yeah,
people hope.
it's the headline that brings people like, what? Oh, I want to read that. I want to get closer to it. I work in newspapers, so that's the
Okay,
strategy.
Tolu. So okay.
Get the headline, and you
Yes.
got the people.
Okay, so Tolu, what I'll do is I'll do it and I'll send it to you, and then you will now tell me Denise is not very good. I adjust accordingly, right? Is that fair?
You know it's not very good. Just do
Yeah,
it.
help you make it good.
No,
I'm not
so
an
that
editor,
Tolu knows how to find the headline. She's serious. So this newspaper thing, I got the top at the
But it's the headline.
Trump.
Actually, I wasn't aware of that, Tolu. So, Tolu, I'm going to task you with coming up with a tagline for Commode Cancer Foundation.
Well
I need
done.
a tagline.
There you go.
I need a tagline for the website.
Okay, I'll think of some. I'll think
Please.
of something.
Yeah,
But it's the headline that grabs people, really. The headline.
absolutely.
So yes, Tolu, we'll get on that.
But you were talking about breast cancer awareness. Is there anything that you can do between that, which is when, in 2 weeks' time?
Yes,
Or
on
when?
our Instagram, I think on our Instagram, I'm not sure. The flyer, we're going to start doing a campaign. We've got some of the flyers out, and then we're going to actually start doing things like facts on breast cancer, checks how to check yourself, differently. But that's going on the Instagram and WhatsApp and the Facebook page. But now that Wale is here, I'll even ask him. Wale,
okay.
This
bye.
Yeah, I love you and leave you. Doing a great job with
I've
this.
got
Thank you,
another
everyone.
thing to do. I'm a speaker at another thing now. I'm late, but
I've got to go as well. Got stuff to do, but
take care of
just,
yourself.
yeah, don't lose the opportunity of breast cancer awareness.
I will
get something out there for it.
I won't.
Okay.
All right.
Bye now.
Thank you.
Take care.
Ladies.
Thank you, darling.
Thank you.
Bye,
And I will chat with you on the other side.
Yeah, no problem, darling. Take care. Love you.
I love you too. Kate.
Yeah, bye.
Kate Ajo. Kate. Ajo. Which I'll do. Go on. You can run as far as you want to go. You can't run so far. Now we did here. Angela, what's up with you? Why are you wearing a shield to cover your head?
She did talk. She's probably on the phone.
She is on the phone.
Okay. Job well done, man. Those the panelists, Dr. They're not. Benga, the lady, the professor, and then Ogbolu. Does he have a brother in the States? He looks so familiar.
I can't answer you on that question.
You can't. Okay, yeah, but no, well spoken, well articulated, and hard facts, like in your face. The question is, as a carer looking, from the outside.
What's into your phone now? It has died. All right, people. Ciao, ciao.